Thank you, Ashwin, for a nice introduction. And as Ashwin rightly told, most of the time when a diabetic patient comes to us, we brand it as diabetic nephropathy. But in reality, non-diabetic kidney disease also exists in diabetic patient. So my topic will be when to suspect non-diabetic kidney disease in diabetes patient. So I'll start with a case vignette, which is a 44-year-old male, non-diabetes 4 years duration, on metformin, sitagliptin and DAPA, and he is having a reasonable control of blood sugar of A1C of 7.2 and no history of hypertension, history of frothy urine, and urine albumin was 3 plus and ACR of 2200 milligram per gram and a serum creatinine of 1.4. So is it diabetic nephropathy? So we will come to this case at the end of the session. So whenever a patient coming with diabetes with renal dysfunction, it can be a diabetic kidney disease, or it can be a pure non-diabetic kidney disease, or it can be a non-diabetic kidney disease superimposed on diabetic kidney disease. So these are the problems, renal and urological problems you may come across in patient with diabetes. Apart from diabetic glomerulopathy, you can have papillary necrosis, you can have ischemic nephropathy, renal vascular disease, drug-induced, because diabetic patients are more prone for nephrotoxicity by the drugs. And it can be any other glomerular disease which you can see in general population. And urological problem you come across, it can be autonomic neuropathy of the bladder, or it can be UTI. So this is a very interesting article came in Clinical Kidney Journal. So what they have done is, it's a retrospective analysis of patients with diabetes with CKD. It was a retrospective analysis. What they did was, they analyzed the biopsy pathological features, and the indication for biopsy was different in many groups. And if you see here, you can see there is the indications are different. One is active urinary sediment and the recent onset of nephrotic syndrome. All these are atypical features of in patient with diabetic nephropathy. So in all these, you can see there is prevalence of this orange color is the non-diabetic kidney disease. There is this entity is existing. So we have global studies comparing the prevalence of this non-diabetic kidney disease and factors predicting non-diabetic kidney disease in diabetes. If you look at all these studies, if you look at the percentage prevalence of non-diabetic kidney disease, you can see it as from 18.2 to 61.4. So that is a very interesting picture. So whenever you come across a diabetic patient with renal dysfunction, always ask yourself, is it diabetic nephropathy? When to suspect non-diabetic kidney disease rather than DN, and when to do a biopsy. So what are the questions you will ask yourself? There are 7 questions to be asked before you come to a conclusion. Okay, so first one is, all of you know, we look for retinopathy. So is there evidence of diabetic retinopathy? Second thing, always we look at the proteinuria. So in proteinuria, you have to look whether the evolution of proteinuria is typical. That is, we have micro to macro. There is a natural history of diabetic nephropathy. And is the range of proteinuria coincide with the diabetic nephropathy stage, and what is the rate of proteinuria progression. Then you have to look into the hematuria part. So whether it is a microscopic hematuria or macroscopic hematuria. So urine examination is the most important thing you have to always do in a diabetic patient. Then you look at the trend of rise in creatinine and fall in GFR. So is it related to the proteinuria patient is having, or what is the rate of renal impairment progression? Then look at the hypertension, whether it is refractory or non-refractory. Then drug history, always you have to check the drug list and the precipitating factors for AKI. Sometimes the patient may be presenting you with some form of AKI, like dehydration or drugs or whatever. So coming to the retinopathy part, if you look at the type 1 diabetes, there is a clear-cut natural progression of different stages it goes through. So after the 5 years of onset of diabetes, if you see the retinopathy and nephropathy correlate well, that is 100% of patient with some amount of nephropathy will have retinopathy. So if you see a patient type 1 diabetes, patient is having nephropathy but no retinopathy, always search for other cause of nephropathy and the renal biopsy may be indicated. Because if you find some non-diabetic kidney disease in patient with diabetes, the prognosis, the treatment plan, everything is different and the prognosis better in a diagnosis of diabetic nephropathy in type 2. So you should note the difference between type 1 and type 2, the relation between the retinopathy versus nephropathy. Coming to the proteinuria part, so you look at the proteinuria, you know the natural progression. So the evolution of proteinuria is typical. That is, it starts with micro, then it goes to the overt and nephrotic range, and then finally ending to the end-stage renal disease. So, is the range of proteinuria coincide with the diabetic nephropathy stage, and what is the rate of progression? All these things you should assess. So, you know the if you look at the natural history of diabetic nephropathy, you can start with the microalbuminuria. This is the duration of diabetes. So there is a gradual progression to the overt proteinuria. And similarly, the serum creatinine also, there is a natural progression, decline in GFR, there is a natural progression with the duration of diabetes. So if evolution of proteinuria is atypical, you should be careful. Development of overt proteinuria without previous microscopic proteinuria, you should be careful. And development of proteinuria is very slow, also you have to be careful. And if development of proteinuria is sudden and rapid, and proteinuria within less than 10 years, especially in type 1 diabetes, you should be careful. So in these cases, you have to search for other causes of nephropathy rather than DKD, and you may consider renal biopsy, especially if you have signs and symptoms of other systemic diseases. Coming to the hematuria part, if the patient urine exam is showing some hematuria, it can be microscopic, it can be macroscopic. So microscopic hematuria, it is in some cases it has shown that you can have microscopic hematuria in diabetic nephropathy, but whenever you see a macroscopic hematuria with an active urinary sediment like ectocytes or RBC cast, always search for other cause of nephropathy and renal biopsy may be indicated. Then you have to look at the creatinine, trend of raising creatinine and fall in GFR. Is it related to proteinuria? You correlate it with the proteinuria progression, and what is the rate of renal impairment progression, which I already shown the natural progression of fall in GFR and rise in creatinine. If it is RPGN like, okay, so if it is a rapidly progressive glomerulonephritis, will have a rapidly progressing or reduction in GFR. So naturally in diabetes, the rate of decline in eGFR, you should know, it is usually 7 to 12 ml per minute per 1.73 meter square per year. But when you introduce ARB or ACE in a patient with diabetes, it will bring down to around 3 to 6 ml of reduction in GFR per year. And to confuse you more, this entity is now becoming more prevalent. That is non-albuminuric DKD phenotype. That's a breakthrough in DKD classic conception. So we all know albuminuric DKD, we have a urinacia of more than 30, they will have microangiopathy, they will well correlate with the retinopathy. In biopsy you get glomerulosclerosis, and it is more common in male sex and correlate well with the A1C. But if you consider non-albuminuric CKD, So here eGFR will be less than 60, but the UACR will be more than less than 30, and there will be macroangiopathy will be predominant and will not get any correlation with the retinopathy. So they will have in biopsy tubular and macular damage more, and the female sex are more affected, and no correlation with HbA1c. So this is a particular phenotypic group we see in type 2 diabetes, non-albuminuric CKD. So this also you should keep in your mind while analyzing this. So what happens in this kind of people is, usually what happens in diabetes, there is hyperperfusion, hyperfiltration, so increase in glomerular, intraglomerular pressure and proteinuria. That is what happens in your diabetic nephropathy. But what happens in this phenotype, there is predominantly ischemia, atherosclerosis. So that leads to hypoperfusion, ischemia, then you will not get proteinuria as you expect. So coming to the ischemic nephropathy, which is the major cause for this non-albuminuric DKD, the ultrasound may be showing small kidneys, the raise in creatinine level, especially when you add AC inhibitor, there will be a raise in creatinine of more than 30%, and usually patient will not have albuminuria if you do the urine exam. Then coming to the hypertension part, okay. So it can be refractory or non-refractory, but if there is refractory hypertension and fluid retention in diabetic nephropathy, always rule out renovascular hypertension, which can be coexistent or it can be pure renovascular problem. Then drug history, as we do in any patient with diabetes, you have to check the drugs, recent drug intake, NSIs, like especially patient is on AC and ARB, they started recently, and reduction in GFR in the initial stage you expect up to 30, then it becomes normal. But if it is keep on rising, more than 30% reduction in GFR, within 2 to 3 months after initiation, you should always suspect renovascular hypertension, and you have to do a renal Doppler or whatever. So, as I already told, the diabetic kidneys are at high risk of affected by nephrotoxic drugs. So, the drug list the patient has taken recently also you should take before you analyzing the patient with renal dysfunction in a diabetes. It can be NSAID, it can be a recent contrast, or any other nephrotoxic drug they have taken recently. So you have to always look for the precipitating factor for an AKA. Sometimes patient may be coming with a renal dysfunction, it could be an AKA also. So the dehydration, recent UTI, the drugs, any cardiac problem, septicemia, all these can produce dysfunction, renal dysfunction in a diabetic. So in a nutshell, so we have to look at the retinopathy. It is usually, if absent in type 1, you should always suspect other cause of diabetic, other cause of renal dysfunction. And in type 2, you should be careful. Even if it is absent, the shorter duration of diabetes and atypical presentation of other precipitating factor will help you to identify, and I'll take 2 more minutes. So, development of overt proteinuria without previous microalbuminuria, and if it is a rapidly progressing proteinuria or a diagnosis itself, you will have a nephrotic range proteinuria. All this will help you to find out NDKD. And macroscopic hematuria and active urinary sediment you have to look for. Renal impairment is very rapid, you look for other causes, and refractory hypertension and the response to ACARB. So there is no specific consensus when to do a biopsy in when you suspect NDKD. But for all practical purposes, if a patient coming with type 2 diabetes especially, you have a clinical suspicion of non-diabetic retinal disease, we look at the fundus for retinopathy, and if there is no retinopathy, you have to look at the duration of diabetes. If it is less than 5 years, especially in type 1, so there is a high chance of non-diabetic retinopathy. and you can go for renal. It is recommended to do a renal biopsy. But if the duration is more than 5 years, still absence of retinopathy, and you look at the urine, urine for hematuria, macroscopic hematuria, there is a likelihood of non-diabetic kidney disease. There you can consider renal biopsy, taking account of other factors also. But if there is PDR is there, and there is if proliferative diabetic retinopathy is there, it is more likely that it is diabetic kidney disease. So coming back to our case, this 44-year-old male with albuminuria, and this urine ACR is very high, and the short duration of diabetes. So looked at the fundus, there was no evidence of retinopathy. USCKB was normal size kidney, and we checked the urine albumin creatinine ratio 6 months back. It was only 24. So this is a very short span. It is equal to this much amount. So renal biopsy came as it is a idiopathic membranous nephropathy and no evidence of diabetic nephropathy. So it was started on steroids and immunosuppressive. So the prognosis of this kind of non-diabetic kidney disease are very good. So to conclude, all renal dysfunction in diabetics are not due to the DKD. So prevalence of non-diabetes kidney disease in diabetics are more than 40% what we have seen, and suspect NDKD in diabetics when any of the predictors of NDKD are present, and consider renal biopsy in indicated cases considering all these, and prognosis of most of the NDKD are better than diabetes kidney disease. So with that I conclude. Thank you.
Thank you, sir, for a nice presentation.